Good afternoon. I'll be talking about some simpler things, and this will be some tips and tricks for people who want to learn ILM peeling in macular hole surgery. So this is a situation of difficult ILM peel. This is the first video to demonstrate the difficulty in picking up ILM due to the premacular vitreous fibers, which are not very uncommon to see in these macular hole cases. The heavy brilliant blue is used to stain the ILM, but here you see this is inverse or negative staining because of something over the surface of internal limiting membrane. I again use the brilliant blue to demonstrate what is there, but it was not staining. Then I use this snare to remove the epiretinal membrane or whatever is there over the ILM. The trypan blue is used to demonstrate what was there, so it is staining some tissue of the some tissue which is present over the ILM. Then again brilliant blue to demonstrate that this is the area. Now you can see the ILM is there and the nick was created and the peeling was started. ILM now, because of the overlying vitreous fibrils, the ILM peeling is not very simple. It is restricted because of the fibrils that was over the ILM. But somehow I could complete the ILM peeling, and then I extended it further. These hemorrhages are of no consequence because they are because of the ILM peeling. So this is the premacular vitreous strands, which may cause problem in gripping with this ILM forceps. So, and this is a very common condition in so the triamcinolone is helpful in identifying these vitreous fibrils, and one should start doing ILM peeling away from the from the negative staining in these cases. So these are the two important tips in this situation. Now this is the second case with the ILM flap everybody is doing these days. So after doing the complete vitrectomy, heavy brilliant blue is used, and this snare is used to create a nick in the ILM. And after this nick, the ILM is lifted and pulled towards the macular hole, and this nick is created temporal to the fovea, and the flap is lifted towards the fovea up to the edge of the macular hole. Now this ILM is more flaps are created, and all these flaps were taken towards the fovea and up to the edge of the fovea. They are hinged at the edge of the fovea. Now after doing this, the ILM peeling is further extended. Now after this this membrane is trimmed with the help of cutter. Here it is very important not to use too much of suction. I do it only with the flow, just without any suction. And after this, the fluid air exchange is performed away from the fovea. So if you do it close to the macula, that we do in without ILM flap technique, the flap will be dislodged, and the purpose of creating all these exercise is lost. So this was about inverted ILM flaps. Now this backflush is very helpful in identifying the edge of the ILMs when you are doing ILM peeling. As you can see here, when you are trying to open this envelope, you cannot. It is difficult to identify the leaves of the envelope. And once you and if you use air, blow air, and these leaves separate. Similarly, if you can see that this paper is difficult to lift, but if you blow air, the edge of the paper is lifted. The same concept can be used in identifying the edges which are loose on the macula area, so that you can very safely pick the next ILM peel. Here you can see with the blow, the edges are identified. And here you can see these ILM is lifted, and you can identify the points where the ILM is loose and can be safely lifted without touching the retina. So this is one simple trick which one can use in doing ILM peeling. This was one case of a very thick epiretinal membrane. I pulled this epiretinal membrane and I found that this membrane was very densely adherent at the fovea. Now you can see that this membrane is vascularized also on the undersurface, and the membrane is very, very thick and dense. I trimmed it with the cutter as much as possible. Then again I inspected the membrane. I thought whether I should remove this membrane, cut it with a scissor, or just leave it, because the membrane was very dense and it was vascularized, so I left it like this. I just leave the video here and ask the panel and the house if something more can be done in this situation. So what more can be done? This is the question I leave it with. Thank you.